Hello and welcome to the Health Report with me, Norman Swan. When Louis Pasteur discovered the germ theory of disease in the 19th century, doctors resisted the idea. It took decades for them to accept it. When they finally did, it was with the advent of the antibiotic era, the creation of drugs that could treat infections. But it didn't take long for resistance to these antibiotics to begin. More and more, ordinary infections are requiring advanced, expensive drugs. And in some parts of the world, occasionally Australia too, there are infections we can't treat with antibiotics at all. Why is it occurring and what are the solutions? Here's some of a panel discussion I moderated at the World Science Festival in Brisbane back in March, looking at that very question. Joining me were Professor Peter Collignon, an infectious disease physician and microbiologist at the Canberra Hospital and the Australian National University. Professor Cheryl Jones, an infectious disease physician at the Royal Children's Hospital in Melbourne, who also has the chair of paediatrics at the University of Melbourne. Dr. Mark Blaskovich, a medicinal chemist at the Institute for Molecular Bioscience at the University of Queensland, and Dr. Crispin Hajkovic, Director of Infectious Diseases at the Royal Brisbane and Women's Hospital. So Cheryl, how have we got into this crappy state that we've got into with antibiotics?
So Norman, I think fundamentally what underlies all of this is that we just didn't appreciate antibiotics for the important resource that they are, a bit like fossil fuels. And there's four real drivers that got us here. The first is that we've overused or misused our antibiotics, both in humans and animals. We've also not appropriately undertaken infection control, so we haven't prevented the spread of these infections when they've arisen.
Old-fashioned stuff like washing your hands.
Old-fashioned stuff gets us every time. We've also not been able to detect these infections when they arise and link that to some sort of public health action. And finally, we simply haven't got the pipeline of drug discovery that there was before.
Crispin, before I forget, let's just cover off on hand washing here. Sure. Because there's now alcohol at the bottom of each bed in most hospitals in Australia. Patients are supposed to demand that their nurse or phlebotomist or doctor washes their hands. None of them do. But to what extent are we actually doing the old-fashioned thing of washing hands in hospitals?
The bad news is we don't do it very well, but the good news is we're getting better. And in fact, certainly nurses...
So you're a half-glass full kind of guy.
Nurses and allied health and physiotherapists are doing it well. We still have a problem with doctors, unfortunately, washing their hands unbelievably. People should ask the doctor, have you cleaned your hands? Very reasonable question, but we know people are too intimidated to ask.
How important is washing hands at home?
That's pretty important as well. There are some studies showing that families that clean their hands and have good levels of home hygiene have lower risk of getting a cold or gastro at home as well. It doesn't have to be with alcoholic hand rub at home. Soap and water is really good for the home environment and makes a big difference.
How rapid's the rise in antibiotic resistance, Cheryl?
Rapid in recent years. So back when we had our first antibiotics with penicillin, in the middle of the 20th century, we just had one infection after the other, the golden staph, the MRSA, and some of the gram-negative infections, E. coli. But in recent years, what's happened is we've seen large groups of infections that are resistant to some of our last line of antibiotics. These are the ones we reserve for the most severely ill people in hospital. And so there have been people who've died from untreatable infections.
To what extent is this made worse by the fact that in hospital today you've got far sicker people than you used to have, at least a dense population of people because we do so much more to them in terms of chemo, transplants and so on?
Look, that's part of the driver, but if you have appropriate infection control around that so that we're both detecting if they have a resistant infection and controlling it, that's important. But the real question is actually what's happening in our community. These are in our aged care facilities, in our general community, in child health centres, but also in agriculture and animal care as well.
We'll come back to that later because we think that it's a hospital problem, but in fact most resistant bugs now are coming in from the community. Is that right, Peter?
Well, a large number can. It depends on the bug. I mean, the MRSA bug we used to think is only hospital. That's a golden staph that's resistant to the standard antibiotics. But now a bigger proportion of those are out in the community. And it's the same for a whole lot of the worst bugs around the world, like tuberculosis. That's not a hospital bug, it's a community bug. And there's a whole lot of bugs that even can come across from agriculture to people, like salmonella, but even E. coli, the commonest bacterial strain infecting people. It's out there in the community. It's not a hospital transmission issue.
Now, Mark, you've got a centre called the Centre for Superbug Solutions. You better start telling us, how do you define a superbug?
So one thing, when we're talking about antibiotic resistance, there's a popular misconception of what that actually means. So just to clarify, when we're talking about antibiotic resistance, it's bacteria that have become resistant to being killed by the antibiotics that used to be able to kill them. It's not your body becoming resistant to the antibiotics, it's the actual bacteria themselves. So in terms of how bacteria become resistant to the antibiotics, there are a number of different mechanisms. And as you saw in the previous slide, every single antibiotic that's ever been introduced, resistance has developed relatively quickly within a couple of years of the introduction. So it's nothing new, and it's just that we're now no longer producing antibiotics fast enough to keep up with the rise in resistant strains. In terms of how they become resistant, there are a number of different mechanisms. So some bacteria can actually change the chemical structure of the antibiotic, so they inactivate it. Other bacteria mutate so that the target that the antibiotic is meant to act on no longer exists. Other antibiotics put up essentially build a better wall around themselves to stop the antibiotics from getting in. And then other bacteria can actually just pump the antibiotics out faster than they can get in, so it doesn't allow the antibiotic to reach its target inside the bacteria.
And how amenable are each of those mechanisms to fixing?
It depends, and there's been a lot of research ever since the first antibiotics were developed trying to come up with new and improved versions that can overcome these different resistant mechanisms. And the most scary bacteria these days are these gram-negative bacteria that have an additional membrane around them that makes it more difficult to get antibiotics in. And so traditionally that's been the hardest type of bacteria to target. And because they have developed so many different resistance mechanisms, it's hard to get around all of them, because bacteria, they generally reproduce about every 20 minutes depending on the type of bacteria. So it's new generations can introduce new mutations very quickly.
Crispin, we can easily get alarmist about this. Is this really as scary as it sounds?
Yeah, I'm really scared about it. At the coalface,
You're not looking that scared, but you're really... So.
I see this every day and all the time. 5 to 10 years ago, if we had a resistant superbug in hospital, we'd form a little cluster and a huddle and ring up all the professors and really wonder what to do about it and have big case conferences. Now, unfortunately, it's just becoming more and more routine work. Every day, every week, we see a patient with a resistant germ. For me, admittedly, that's mostly people who've returned from overseas travel. But the novelty's gone and the numbers are increasing, and I'm really worried about it. I wonder what it means for my children and my family as well.
So tell us a story about overseas travel that you've seen.
I think a really good example of this is a young woman I managed at my hospital a few years ago. She was a dual Australian-Pakistani national. She was in Karachi and developed acute leukemia, so blood cancer, and had her initial chemotherapy in Karachi. She then flew back straight to Brisbane to receive a bone marrow transplant. She came in on a Friday night, and unfortunately on Sunday she passed away from an untreatable gram-negative bug called NDM1. It's a bacteria that's essentially resistant to almost all antibiotics, and it went wildfire. She received appropriate antibiotics, broad spectrum, 5-6 different antibiotics, and unfortunately she just progressed through that and died anyway. And that's what antibiotic resistance looks like, and that's why it's so scary.
Did it spread to anybody else in the hospital?
That time, no. But now, every time we receive a patient from overseas, we immediately put them in isolation, gowns, gloves, single bathroom, all of that sort of stuff on the grounds that they almost certainly will be colonised with a resistant bug. And only once we've proven that they're not colonised do we then take them out of isolation and put them into the general wards or whatever. But I have to say, for the hotspot resistant countries like India, the subcontinent, Southeast Asia, everyone has a resistant bug if they've been there for more than a few weeks.
Take into account that particular bug in England and Scotland, there were cross-transmissions where people came back from the Indian subcontinent, were treated, and then it cross-infected in hospitals.
We've certainly had other outbreaks of resistant bugs from a single person coming overseas, and then dozens, hundreds of patients becoming infected in the hospital, unfortunately.
So what's our antibiotic use in Australia by doctors? Our antibiotic prescribing rates?
We are one of the highest OECD countries of prescribing antibiotics around the world, and we know that about 70% of that occurs in the community. There's been recent work with the ORA Antimicrobial Use and Resistance Australia report put out by the Safety and Quality Commission, which is suggesting that a lot of those prescriptions appear to be where we know for inappropriate use.
So they're giving it for viral respiratory tract infections?
For example, or what we call asymptomatic bacteriuria, so where people have actually tested urine with people without symptoms, found bacteria and given antibiotics in that setting, which we know is not needed.
And we're also not giving the right antibiotic when they're giving it.
Well,
Go back to urinary tract infection, the one that's recommended is a very simple old antibiotic, and it's not used as much.
It's not used as much, and it doesn't work as well because there's so much resistance. But one of the real problems in places like Australia is mostly we're using antibiotics to treat viruses, and guess what? They're not killed because it's respiratory tract infections where, oh, look, you're a bit sick, here's this magic potion, will make you better.
So GPs aren't stupid. They obviously know that that doesn't work. Why do they prescribe antibiotics at that rate? I mean, we must know why.
Well, I'm not sure we always know. It's a culture of society as well. But at the bottom line, we use twice as much antibiotics per person as, for instance, the Netherlands or a lot of Scandinavian countries.
So what's the difference?
Well, the difference is I think they have a better social cohesion and a more acceptance that it's less about the individual, but it's more about the community. So if you're a doctor and you're not sure whether it's viral or not, or bacterial, well, let's wait and see and only give it to you if we really have much better evidence that's bacterial.
Yeah. I think part of the problem too is there's the perception that antibiotics don't have any side effects, so it's safe to give them even if you might not really need them. And increasingly there's more and more awareness that, yeah, they do have side effects and not just the chemical side effects. Altering the microbiome can have significant effects on your health as well.
Yeah, the more we know, the worse it looks, because if you give young children antibiotics, it changes their microbiome, which is the millions and billions of bugs you've got in your gut, and that can lead you to increase obesity, increase whole lots of other problems they've found later.
Yeah.
But in older people, for instance, there's something called Clostridium difficile, an infection that results from using antibiotics. You may get the bug through various ways, including food. You get antibiotics, it lets them multiply up, and you can get very sick. If you're in your 80s with a lot of these strains, you've got more than a 10% chance of not surviving 30 days.
You've taken an interest in this microbiome issue, haven't you?
Well, I think that we're only just realising it is a bit like a rainforest. It's not just the bacteria in there that exists in healthy people, it's the fungi, the viruses, but also their metabolic products. And research we're doing around the country, but through the University of Melbourne, is trying to understand through our studies where we're following up children for long-term effects, what are some of these long-term consequences? And Peter spoke about effects on your ability to respond, to infections, but in the longer term, things like the way we metabolize food and obesity, and then long-term consequences, heart disease may also be part of this. So we really need to understand better some of the collateral damage that happens when we prescribe antibiotics unnecessarily.
So in the Australian context, Crispin, what would a post-antibiotic era look like?
There was the pre-antibiotic era before the 1900s when the medical profession coped with infections with things like surgery, amputations, sending people off to the hills in Switzerland to live in sanatoria and so forth. And unfortunately, palliative care was a big part of the treatment of infections in those days, and that's what we're potentially looking at in the post-antibiotic era. This is the idea that we're in the antibiotic era now, and then once the antibiotics are all burnt up by resistance, we'll be in the post-antibiotic era. There's a gene called MCR1 now, mechanism of colistin resistance 1, transmitted by this little mobile plasmid thing. It's a little bit of DNA that can jump from bacteria to bacteria, and it is conferring resistance to a class of bacteria that are already resistant to all antibiotics. So they are truly pan-resistant bacteria now. They are literally resistant to all antibiotics, and that's the end of it. How do you treat them? I don't know. I don't have any drugs in my arsenal to treat that anymore. It's surgery, vitamin infusions, and it's palliative care, and good luck.
And if you vitamin infusion.
If you look at the 1920s in Boston, for instance, if you had a golden staph in your blood or the pneumonia germ, there was an 80% chance you were dead within 30 days. Now, if you get those serious infections now, it's not good, but the mortality rate if you've got golden staph in your blood is about 15%. Now, if we go back that the antibiotics don't work anymore, well, we're back to the 1920s, which is a very high death rate with serious infections.
And a lot of other...
And a lot of suffering as well.
And a lot of other common medical procedures that are common, anti-cancer therapy becomes impossible because...
The major advances.
It takes down the practice of routine medicine. So if in certain hospitals...
So in other words, no bone marrow transplant anymore, no heart transplants, kidney transplants, because antibiotics are fundamental.
Open heart surgery, all of these major advances.
Even hip and joint replacements rely on preventative antibiotics to stop a few bugs growing in the artificial thing. So even things we take for granted may become so complicated by infections you can't, do it anymore.
If you develop leukemia, blood cancer in Calcutta now, you have two options. You can either leave Calcutta and go somewhere else, or you can die from leukemia. You can't have chemotherapy for leukemia in Calcutta anymore because you have a 50 to 90% chance of dying from an overwhelming bacterial infection that no one can treat.
So it sounds like you're going to have to come to our rescue here, Mark.
Well, So there's been a lot of efforts trying to develop new antibiotics. Part of the problem is that most major pharmaceutical companies are no longer investing in antibiotic research, and that's largely due to economic factors. So for them, it costs the same amount to develop a new drug for another indication like cancer.
Which has a lifespan of 20 years.
Yep, and cholesterol-lowering drug, which people have to take every day for the rest of their lives. So for cancer therapy, the amount that they can charge for cancer therapy, there's a recently approved cancer therapy with a new technique called CAR-T. It's costing between $350,000 to $450,000 for one treatment course. Whereas an antibiotic, you can't charge more than maybe $1,000 a day for the best antibiotic, which you'll take for 7 days. So the economics just don't stack up.
But I thought organizations like the World Health Organization had tried to get regulators to make it cheaper to produce antibiotics so that the regulatory regime was a bit lighter, so that it didn't cost you $100 million to get it to market.
It doesn't, because it still has to go through the US FDA approval and the European Union EMA approval and the clinical trials required to do that. Because antibiotics are so successful, in order to get an antibiotic approved, you have to show equivalence to an existing antibiotic which cures 90 to 95% of the people. So the barrier to showing equivalence is so much harder than an anti-cancer therapy where you're trying to improve on something which is maybe curing 20% of the population. So you have very large trials which are costing $100 million to run.
So you've got a volume relativity here, for example, with antibiotics and anti-cancer drugs, for example.
Yeah. So from the time you have something in a test tube, so if today we discovered something that killed bacteria, looked wonderfully good at a potential antibiotic, it's 10 to 15 years before that would get approved for use in humans. And it's that time delay that's a real worry. So if we don't start investing in antibiotic development now, in 10 to 15 years where we have these the strains that can't be treated by anything else prevalent everywhere, it's too late to start investing into the research. Just in terms of the economics, there are 43 antibiotics currently in the clinical development pipeline, and there are 3 stages of clinical development. So phase 1 in humans, you're just looking at safety. Phase 2, you're starting to look at efficacy, and phase 3 are larger scale trials where you're putting in anywhere between 500 to a couple thousand patients to see that it's A, safe, and B, is able to treat the infection. So right now there are 43 antibiotics in that process compared to over 800 anti-cancer drugs.
Peter, people talk about One Health here. Just take us through what that actually means.
Well, One Health really means we're looking at the total picture, and that means not only people in hospitals, but people in the community, people in nursing homes, but much wider than that is what we do in the agriculture, for instance, affects us, because both with the manure that can get into the waterways we can take in, but what is used to fertilise, for instance, rock melons, for instance, that may actually have effect with not only listeria but antibiotic-resistant bugs. And so it's really how everything goes around and is interconnected. And if we look at antibiotics, the majority of antibiotics like penicillin, they're not synthetic products. They're compounds produced by fungi or other bacteria that are there to protect their turf and maybe signalers. And so what we've done is found these and been able to extract them. But by being in the natural environment, it means that resistance is in the natural environment too. We have got more and more globalisation of trade, which has got a lot of advantages. But we also got to be taken into account that not everyone has the same water quality as we have. Not everybody has the same rules that are followed. So you've got to be very careful that you actually do have good international regulations that are followed, and there's something called Codex, which is set to design and protect public health. And my view is that's where we've got to get involved and make sure not only has that appropriate standards for pesticides and chemicals, but we look at superbugs and saying, look, the food I eat should not have superbugs in it or drugs.
Cheryl, can we use data in a better way here?
We definitely can, Norman. So there's a lot of pieces of information people know, not just Facebook, that's capturing data on us, the way we have antibiotics prescribed to us, what happens when we present to doctors or in hospitals. What we can be doing is getting a better understanding of where are antibiotics being prescribed and for what purpose, and feed that back so that there is better regulation of not just in hospitals, which happens now, but in the community of where is the over-prescribing happening, where is the misuse happening, so that can not only control where it's been over-prescribed, but also allow for educational programs. The other thing too is that we can better capture data from the microbiology lab about the resistant infections and be able to feed that back in a feedback loop to public health control rapidly when we need responses for these things.
But I mean, this is just fantasy land, isn't it? I mean, you don't get private pathologists in Australia who do the bulk of the work sharing they're on different IT platforms. They don't share their data with the public system. It comes in a silo to the GP. They don't want to share their IT system because that gives them their market leadership. We're not working in an environment which is conducive to sharing data. And then there's privacy. Medicare doesn't want to give up their information. And in any event, Medicare doesn't have it because all they've got is an item number 23 for a GP. It doesn't tell you why somebody went to a GP. GPs are resistant to the data coming off their medical records to be analysed because they think they're going to get blamed for bad practice.
This is changing though, so it's changing in a couple of ways, glacially. But I think we recognise across the country that we've got to better connect our healthcare system.
But we've been saying this for 25, 30 years.
Absolutely. But I think we've got the technology now to do that, so that the capacity, it doesn't matter having different systems. There's actually technology now that can actually extract that information in servers and feed that back. But we still have to change our regulations across state and federal governments about privacy, and we have to have the governance and the protection around that information as well. But it's happening.
I don't think it's as bad as you're making out.
It is as bad as I'm making it.
No, I don't think it is. It's not like Scandinavia where they've really got it together.
No.
But for 20 or 30 years, for instance, at least for 10 years of that, the private sector has been involved in a group called AGAR, the Australian Group for Antimicrobial Resistance, where we do look at what's in the community, and a major private laboratory network is in that in Queensland. We have now got the Australian Quality and Safety Commission, who has got programs out there to capture this data from lots of laboratories. Our laboratory in Canberra is one of them, but so are now multiple laboratories all around Australia, including some in the private sector. So while there's a lot more work that needs to be done, and yes, it'd be good to fix it with the Medicare data so you can actually do more intelligence on it, it is much better than it was 10 years ago. It's not as good as Scandinavia, but it's much better than the US.
And when it works really well. So really practical.
And when does it work?
A really practical example of this is that you can look at GP prescribing habits for antibiotics, and so the Chief Health Officer of Australia wrote a letter to the top 20%, I think, of antibiotic prescribing GPs, just saying, hey, did you know that your practice is right down one end of the antibiotic prescribing practice? I know this personally because two of my GP friends rang up and said, is this letter from you, Crispin? And I said, no, it wasn't. It's from on the China. That has a massive impact on GP prescribing habits, just to have it pointed out that you're an outlier. And we have hit peak antibiotic now in primary care. So we prescribe about 10% less antibiotics than we did in 2010. So there is some progress there.
It's turning.
One of the other areas that worked is, exactly the program that Crispin's leading around Queensland, which is what we call antimicrobial stewardship. So this is something that Australia has really led the world in, particularly at the moment it's in hospitals, and we need to obviously get that out into our community practices. But it's mechanisms whereby we restrict the use of antibiotics to appropriate indications and match to our evidence-based guidelines, and there's feedback there as well, and there's very clear evidence that has many benefits, not only reducing harms from antibiotics but also resistance as well.
So, Crispin, just tell me how the stewardship program works in Queensland.
So along with the incredibly important work that Mark does creating new drugs for us, and I think that is a very important part of the solution, the other really simple solution is to use the drugs we've already got properly and well. So the program that I lead and help to run is a statewide program, particularly trying to get resources into rural Australia, rural Queensland, where there are way fewer specialist pharmacists who have expertise in this area, and really doing really simple things. So if a doctor at Longreach Hospital now wants to prescribe an antibiotic for more than 3 days, they just need to ring me up and justify it to me. It's all they have to do. And with that simple step, antibiotic use has fallen by 22% in the space of a few months.
You're so scary.
Well, in fact, I don't get many calls. Because what actually happens is, bit of a hassle ringing up Crispin to get the approval, or just actually check if the patient really needed an antibiotic, and often go into oral antibiotics and send the patient home, or decide that the patient doesn't really need antibiotics at all in many cases. So that's a really simple program. Things like just having a guideline so that the doctors and the pharmacists and nurses all sit down and say, right, for this infection, this is what we're going to use. This is the standard practice. And if you then deviate from the practice, you just need to justify that. And that just by itself has a big impact on reducing antibiotic use.
But the key thing is that Australia has done is they've linked this to a hospital accreditation.
Yeah.
So, and that's been really a major internationally recognised feat, and that's what we've got to do for some of these other things.
So just explain to people what hospital accreditation is.
What that means is that for hospitals to be funded and to operate, to be able to care for people, you've got to actually show evidence that you've got a program that's effective for looking after your antibiotics and using it based on evidence-based guidelines of appropriate use. Otherwise, you can't operate effectively.
So has resistance dropped as a result?
Not yet, but you wouldn't expect that to happen straight away. There's going to be a lag. I guess the very first thing is to arrest the further development of resistance, and that germ that Peter mentioned, C. diff. That's the first thing to achieve. Then we hope over years we will see a reduction in resistance, and certainly in countries that have done this well. So Scotland's got a good reputation for doing this, and in the Netherlands and Scandinavia, where antimicrobial stewardship has been running well, effectively, and in the community and in hospitals, all of the parts coming together, there has been a decline in antibiotic resistance. So it works, it just takes time.
And again, if you look at animals, food animals in Denmark, they can show when they've stopped using antibiotics, the resistance went up and it comes down. It doesn't go to zero, and that's an important issue. The resistance never goes away. So if you're down here and you start using again, guess what? It goes up. Yeah. But there are a lot of examples in people, many more in animals because you can control it more, and in fact there was more use, but you can show that at the very least it stops it going up, and in a lot of cases you can make it come down.
So, Crispin, it's hard to know who to blame here if you want to find somebody to blame.
I am on the record as saying doctors are to blame for this, but that was 5 years ago, and I've had a lot of chance to think about this. A lot of my colleagues have asked me to think about it very seriously. And I guess...
it's a very lonely life out there, isn't it?
The reason I thought that was because really this is nothing new. In Florey's initial development of penicillin in 1941, within months of the development of penicillin, they'd already demonstrated antibiotic resistance in culture. In 1941, within months of the antibiotic becoming available, and by 1957, the American Hospitals Association was pleading with doctors to use antibiotics responsibly. Many of us on the panel weren't even born then, and this is nothing new.
How kind you are. I know
the message has been
is.
out there for many, many years. And if something's so obvious and you fail to do something about it, then that's a big problem. But what I guess I've thought about a lot more is that no doctor, very few doctors, no doctor that I know ever comes to work meaning to do harm. So unfortunately, actually, doctors think they're doing the right thing. They think in this one particular circumstance they're helping the person, and I think that's ritual, it's culture, it's an expectation from patients that they'll get an antibiotic even if they've got a cold. The common cold is caused by a virus, and antibiotics just do not work for the cold. They can't. They just don't attach to the virus and kill it. There's no possible way that could work, but we have a culture of antibiotic use here, and it's the culture and ritual around antibiotics is what really needs to change, and that's not really the doctor's fault. It's a whole society problem, and leadership and expertise is what's going to fix it.
Professors Peter Collinyoung and Cheryl Jones, and doctors Mark Blaskovich and Crispin Hajkowicz, speaking as part of a panel on bugs and drugs, the resistance wars, at the World Science Festival in Brisbane in March. I'm Norman Swan, and this has been The Health Report. See you next week.